Hi, and welcome to Fairview Range Focus. I'm David Hall, Senior Vice President and Chief Administrative Officer for Fairview Range here in Hibbing. Today we're going to talk with a couple individuals about care management, and I'm joined by Nancy Hyduke, who is the Supervisor for Care Management, and Nancy Berland, Utilization Review Coordinator. So thanks for joining me. I'm looking forward to visiting a little bit about care management. So, and if we may, let's start with that so that we can give everybody kind of a sense for what exactly is care management department? What is that, just in general terms?
Okay. Care management developed in our hospital approximately 10 years ago. And it was an identified need that as we're starting discharge planning on admission, we needed to have specific people in a department who could help coordinate that. So, we are a department of 7 currently. Okay. We contain our UR Review Coordinator, Nancy Berland. I am an RN case manager, primarily working the utilization review side. We have another clinical RN case manager who actually does utilization review and discharge planning. We have another RN case manager who primarily works just the discharge planning side for a patient, and we have 3 social workers. So we've identified needs, and we have just been improving. Our latest endeavor this past summer is we now have a social worker or a case manager in our ER department, okay, Monday through Friday, to help with already beginning discharge planning, or they may identify that a patient who's just visiting the ER may have some services that they can engage them in before they leave, which might prevent a hospital admission down the road. Okay. So that's been a new vital change for our department that we're very excited about. So we're very diverse, but I think putting us together, and we work hand in hand with the whole team, okay, multidisciplinary team. We have worked side by side with our hospitalists, who have been a wonderful addition to our facility, and we work with the primary care physicians for our other clinic. So we are right there for discharge planning right from the get-go, and we're involved with the patients' families, all of the multidiscipline teams, to help develop a comprehensive discharge plan for our patients.
Okay. So discharge is obviously a really important part of what you
Yes.
do and why you exist and the different roles. So, okay, forgive me, but why is that important? Why is it, I mean, and I know every hospital really does focus on that as far as the discharge. Why has that become so important today?
We are under so many rules and regulations. CMS, which is the Center for Medicare Medicaid Services, mm-hmm, we have rules and regulations that we need to stay in compliance with. And so we, with their rules and regs, need, and with reimbursement, need to be sure that we are working very soon with these patients to help develop that discharge plan, to get them to the next setting. Okay. I've been a nurse 33 years at the hospital, most of my years in this type of work, mm-hmm, but in those 33 years, I've seen services on the outpatient basis being added that we never saw 30 years ago. Mm. You know, we have assisted livings now, rehabs more, we have foster care, we have, just I can go on and on and on about the services that are provided, outpatient chronic disease clinics, wound care. Mm-hmm. So we have the capability now to get people moved to the next level of care sooner because of these additions of outpatient services. Mm-hmm. Because of that, we need to be working very quickly with our patients. You don't stay in the hospital any longer until you're completely well, because CMS realizes that we can move you to another level of care to complete some of this work. Mm-hmm. The patient may, after a surgery, may need additional type of strengthening. Okay, we can look at a skilled nursing facility just for the physical therapy, occupational therapy side of their stay, or a rehab center. Either way, we don't need to keep them in the inpatient hospital setting longer than we need to. Primarily, tell me if I'm wrong, Nancy, when a patient is ready for the next level of care, that's when we need to facilitate that discharge to the next level of care.
Because basically Medicare isn't going to want to pay for the highest level of care for something that can be done at a lower level of care. Okay. So it saves the whole Medicare system dollars.
Right. Okay, that makes sense. So really trying to start dealing with discharge planning from day one is all about making the length of stay as short as possible, getting them to another level of care that's more appropriate, maybe less costly as well.
Correct.
Okay, good, thank you. That kind of gives us context and everything. So, but I know we want to talk a lot bit about utilization review, and I think one of the questions that we wanted to talk about was observation. And I know it sounds like that's well, Nancy, you can explain it far better than I can. Help us understand exactly what observation beds are and what that means.
Okay. Well, observation services were basically what CMS said was an answer to hospitals being upset about denials for inpatients that came in for short stays that they said didn't meet all the medical necessity. So CMS came up with an observation level of care status where the person is actually still an outpatient, and they come in, and when the doctor examines them and he can't quite determine, do they need to be an inpatient or can I discharge them from here? They now have an option to keep them as an outpatient, as an observation in a bed where they can stay up to 2 midnights. And at that time, that gives them enough time to run tests and to determine whether or not they need to be converted to an inpatient or they can be discharged.
Okay. So, but that technically is not considered an inpatient, is that right? There's a difference between the two?
Correct.
Okay.
So an inpatient takes a doctor order. Inpatient care never does anything custodial, neither does observation, so that's one thing they have in common. Neither one, Medicare never pays for custodial care.
Okay.
So in an inpatient, they consider it a complex medical decision that an MD must make, where they look at age, any other diseases in your history, whether or not what you have right now, it would be dangerous for you to go home with without being medically observed. So they take all these complex decisions and then they decide how sick you are and what we're going to be doing for you, and then they can write an order to have you be an inpatient.
Okay, so you can be admitted as an observation patient and be changed to inpatient.
Correct.
Is that right?
So
okay.
anytime during your stay, you can't, the doctor, if he feels that he needs to continue services, you're not showing the improvement he wants, he could switch you over to an inpatient, realizing an inpatient would be someone that you planned on staying more than 2 midnights.
Okay.
And so that's basically when they could do it, but you can't go back. The doctor can't just on his own go back and make an inpatient an observation. So they can switch him to an inpatient at any time.
Okay. Now you said, Nancy, custodial care, that Medicare does not pay for that. Help us understand, what exactly would that mean, custodial care? What would that be?
Consider it kind of like when you do maintenance on your car.
Okay.
You're expected to change the oil. You're expected to change the tires. You're expected to do different maintenance work. So custodial care would be that type of care that doesn't require a skilled nurse, but you might require someone to make sure you eat, make sure you take your meds, make sure just simple, some of the daily living type things are just custodial in nature for helping you to continue to live well.
Okay. Somewhat more routine than kind
Correct.
of things. Okay. All right, good. That helps. And I know I've heard the term medical necessity quite a bit in regards to the patient status and what care is provided. If I say Nancy now, either one of you can answer. But
You can.
Nancy Hyduke, maybe you can help me with that. Tell us a little bit about medical necessity, what exactly that means.
Okay. CMS calls medical necessity care that needs to be provided during a stay at the hospital and expected to span 2 or more midnights. Now, I want to expand on that a little bit.
Okay.
From the utilization review standpoint, it's deeper than that. When a patient comes into the hospital, Nancy, Berland, and I every day work our cases. We are looking at something I'm going to call severity of illness. We actually abbreviate it SI. And in layman's terms, it basically means how sick are you? So we have that component that we have to look at when we work our cases. The second is the intensity of service, or IS. Okay, you're this sick, what are we going to do for you because you're that sick? So every day we have software that we use that we put every patient criteria, plug it into our software that shows us whether they have enough severity of illness and enough intensity of service to be the level they are.
Okay.
So are they sick enough, or are we doing enough because they're here? Now, granted, we're looking at that because we're hoping that we can have them be inpatients, and that's correct. And make sure that when a doctor does put in their order, that the order they have chosen for that patient is actually the correct order by CMS guidelines and rules. So we will be working every case every day to determine that it's accurate, and we will be using those two sets of criteria to be sure they are met. Now, you could meet severity of illness, but we might not be doing enough on the intensity of service. We certainly don't go to the physician and tell them, okay, you need to add some more things here. That's not how we work. We basically work our cases. We have a process if they don't meet, which actually would be another whole show in and of itself on what we would do. But we verify every admission to be sure that they're appropriate level by using the medical necessity criteria for both intensity of service and severity of illness. How sick are you? And if you're that sick, what are we doing for you that would qualify you to be in the hospital?
Okay. So do either of those correlate to whether the individual is considered an observation patient or an inpatient?
Yes, yes. We, again, as we work our cases, their level has already been determined by the physician. We're just validating with our physicians that they have chosen the correct level of admission. We're basically a resource for them.
Okay.
You know, to stay in compliance with the Medicare, Medicaid rules to be sure that we have people in our hospital at an appropriate level. So, yes, it can determine whether the outcome should be an observation or whether it should be inpatient, and we're validating that with our doctors. We may get a question asked by our physician when they're trying to determine, you know, based on regulations, does this sound like a good observation? And they will give us their list of criteria, and we might use our resources then to help guide them. But they ultimately are who choose the level of admission for our patients.
Okay. Nancy, you mentioned is it 2 midnight rule? Did I say that right?
Yes.
Maybe you can talk a little bit about that further. I know that that's something that has been published and that a lot of hospitals are obviously dealing with that as far as that rule. Can you help us understand exactly what that means?
Well, I believe it was last October, CMS told us that they were going to start a 2 midnight rule. And initially, what we had thought is that their purpose was that those observation patients that stayed greater than 2 midnights. Now, we don't have a lot of that happening in our facility, but if you read a lot of journals and articles, it'll talk about out east, there were observation patients staying 5, 7, 2 weeks in an observation level of care. And people were quite angry about the deductibles are different, the co-pays are different, so they were getting much higher bills than if they had been in inpatient status. So when Medicare came with this 2 midnight rule, they said, if you think the patient will be in longer than 2 midnights, you should consider having them be an inpatient.
Okay.
And so initially we thought that's all they were going to be doing. Well, then they ended up saying, on the other hand, if you have a patient that doesn't stay 2 midnights, they should be an observation. So we had a lot of people that would come into our facility, and before the 2 midnight rule, they would stay 1 night. You know, maybe they came in with diabetic ketoacidosis and needed to have an insulin drip in the intensive care unit. Maybe they had atrial fibrillation and needed to go into the intensive care unit for a drip and for telemetry. Well, those things tend to turn around really quickly. And even though they're in the intensive care unit, they still turn around quickly and they don't stay 2 midnights. So Medicare is now saying those type of patients, they should really be observation, whereas they had always been considered inpatient. So that 2 midnight rule really changed patients on both ends as far as who was an inpatient and who was an observation now. So
Okay.
that's,
Okay.
do you have anything to add to
No,
that?
I think that covers it.
Okay. It sounds complicated. So we're talking about Medicare and CMS, which are maybe somewhat one and the same. So as a hospital, I mean, could you just say, you know what, that's really too complicated. We really don't want to do it that way. Could you just say, no, we don't want to do it that way? I mean, what do you have to follow their rules to that extent?
Yes.
It's called compliance with
Compliance.
Medicare. If you want to be part of the Medicare program and you want your Medicare patients to be able to come to our facility and have Medicare pay us, it would be to our benefit to follow the rules so that we can have Medicare patients and get paid by Medicare for the care we provide to our patients.
Yeah, makes complete sense. I think I asked the dumb sounding question, forgive me, but I know that in some cases, people in the public sometimes I think kind of hear some of that and kind of feel like, well, that's a silly rule. Well, why do you do it that way? And not realizing maybe that, well, it's really not our rule, that it's something that we have to deal with.
Or another thing is, one of the things we find is patients coming in and saying, I went to the hospital, I stayed overnight, I must have been an inpatient. And so that has been something that's been real confusing to patients. They don't see it as, sometimes I'll try to tell someone it's like if you went to the dentist and he had to do a lot of procedures and he kept you for a number of hours. When you're done, you go home. You don't say, well, it's late in the day, it's after 4 o'clock, I'm going to stay overnight. So an observation patient, if you think of it as an outpatient, you come, you get all the cares that the physician feels you need, whether it be a diagnostic test, an x-ray, an IV medication, a fluid, but when it's done, then you go home. Whereas an inpatient would need, continued, IV antibiotics for a longer period of time. They're not expected to get well as quickly as someone who's in an observation bed, but they would both stay overnight. An observation, hopefully no more than 24 to 48 hours, and an inpatient would be expected to stay longer than 48 hours.
Okay. Okay. So is there any conditions or diseases that you could say that, that you might typically say that, well, gee, patients who are admitted more in the observation are dealing with these kinds of things versus patients maybe that typically aren't dealing on the inpatient side? Does that make a difference, or do you see any patterns there?
One of the biggest diagnoses that is chest pain.
Okay.
Chest pain is one of the biggest rule-out chest pains, to be sure.
Okay.
So we will see, I would guess, almost all of our rule-out chest pains. I'd say all of our rule-out chest pains are admitted as an observation patient.
And chest pain, of course, being related to heart condition, a heart attack
Correct.
or something? Okay.
Correct. Now, of course, if something shows up in that evaluation, and yes, things have changed. But if it's truly just a rule-out chest pain, we will always see observation.
Okay.
Yes, that's to me the best example to give for our
That's
hospital.
a good example. And I'm
Yes.
thinking that might be somewhat common.
Very.
Okay.
Very. Yeah.
Okay.
And just to give another example, we see a lot of pneumonia. Pneumonia can go either way, quite honestly. We can get patients that come in, we have an oxygen saturation that we measure, so how much oxygen are they getting. And we may have criteria when we're working our computer screens that will show that, yes, they're sick, yes, they do have pneumonia, it's confirmed, but some of the other symptoms aren't quite as severe. Their oxygen saturation, or the level of the oxygen in their blood, is actually higher, so they're not being decompensated, needing oxygen. They may not even have really a high fever, or the white count, but they still need to be watched because they could flip to becoming more severe.
Okay.
And so we would want to watch that patient. So we have pneumonia patients sometimes being admitted observation and sometimes being admitted inpatient right off. And it really, again, is the physician's call. They may feel that pneumonia can turn around in 24 hours. And if that's the case, they have made a correct level of admission by putting that patient observation. They just feel they may need to give them a little boost in something, start them on maybe an antibiotic. Sometimes it's just PO antibiotics, believe it or not. And by the next day, they're okay to go. Whereas someone else may come in with an O2 saturation that's really low. They're having to get on O2, which they've never been on before. They're running a higher fever. Their white count is high. So there's a number of criteria, and that doctor may say, oh, this one is not going in 24 hours. This one, for the most part, is going to stay at least 2 midnights.
So if a patient is admitted in an observation status and maybe looked to be discharged, within that 2 midnight rule, is there any kind of appeal? If as a patient, maybe they feel like, I feel like I should stay here longer or something. Is there any kind of an appeal or anything that the patient can do, or family?
The CMS basically says the beneficiary has no avenue for appeal under the observation status.
Okay.
It is an outpatient order. It is billed under an outpatient Part B on the Medicare. So, no, there are no avenues to appeal.
Okay. So kind of the
Not
rules
like
are the
inpatient.
rules.
The
Yeah.
rules are the rule.
Yeah.
Again, this isn't our rule,
Right.
but we
Right.
have to stay compliant with it.
Right.
Yes.
Right. Yeah, and Nancy, you described that really well as far as the reasons that hospitals follow those rules in regards to reimbursement and being
Yes.
able to continue to be participating within that system. So, last question I would like to ask, I think, or maybe clarification in regards to, we're talking about CMS, we're talking about Medicare. So what's the impact someone comes in who has private insurance? They have insurance through Blue Cross and Blue Shield. Do these same rules apply?
Well, most of the commercial insurances kind of use Medicare as their guideline. So when Medicare started with the observations, at first we didn't see a lot of commercials doing anything with observation.
Okay.
But slowly they started seeing where it would benefit them also. But their rules wouldn't be exactly the same. So unfortunately, that's where the policy you have as an individual, it would say what they would pay for an observation, what the copay, and it may be totally different than Medicare. There may be more things they'll allow as a Medicare observation than Medicare would. So no, the rules are not the same, which makes it complicated to talk to mixed groups, because what Medicare may say may not be totally the same as for commercial insurance.
Right.
Because take for instance, there's a couple items of things that Medicare says, even if it's one day, they can be an inpatient. Maybe you can tell them a
I
little
will
bit
give
more
that.
about that.
We have those cases that the doctor may have admitted inpatient, and the patient, for some reason, isn't going to be staying that second midnight. There are some exceptions to their rule. Okay. One, and this one actually could be up for a look at by Medicare. If the patient all of a sudden clinically improves very quickly, we have had that happen. At the admit time, the doctor feels, oh, there's no way this patient will be going in less than 2 midnights. So they admit them inpatient. By the next day, they have improved greatly. And so the physician, of course, would not discharge, but they have to document in their record that they pretty much have improved that quick that they can discharge, but that also still is up for review. If Medicare could look at that case, and they would be looking for particular documentation. Yes, the doctor would have his 2 midnight certification in his order, but they also would be able to see some documentation that this was turned around much quicker than they anticipated.
Okay.
Now, part of us, we do what's called a post-discharge review on that then. We will look at it. We have another whole process that we will look at that case. We have people that we review records with, and they will indicate to us whether, yes, that's good, leave it. Just leave that particular case inpatient. We feel it's a strong case to stay inpatient even though they stayed only 1 midnight by the documentation that's in the chart. But of course, they could also say the opposite. No, this really was an observation. So we do have a process in place that allows us to look at those in a post-discharge review setting. Another reason that they could be only one is death. You know, we don't anticipate death always. And so that's a legit reason that there might be only a 1-night stay. Transfer to another facility. There may be a need for that patient that has to go to a larger hospital that has specialties that we don't have here. They understand that. So a transfer to another facility. A patient leaving against medical advice. The AMA, they wouldn't penalize the hospital because the doctor certainly does not want that patient to go, but they have signed a release to sign themselves out.
Right.
So they were not penalized for that. There's also, if a patient is admitted and then all of a sudden they feel they need to bring in inpatient hospital services. That's another, okay, their 1-night medical condition warrants it, but then there's been some decision probably made between the patient, family, and physician that it warrants it to go into a hospice setting. That would be another reason. The third primarily is for surgeons. It's called the inpatient only list. CMS has developed a list of certain surgeries that they say have to be inpatient and length of stay doesn't matter. So there are certain particular surgeries that will be done that even if they go home the next day, they have to be inpatient. And funny enough, we had one I think that went the same day. But at that point, that still was on what we call the inpatient only list by CMS. And so we have to, again, comply with their rules. We have to put them inpatient. That is a designated level that is run and indicated by CMS. So we don't have a choice in that.
Okay.
So those would be the reasons you may see the one night.
Or a ventilator too.
And ventilator. I did forget ventilator. Yes.
Well, we're going to have to leave it there. I think we're about out of time. I can tell this is probably a subject we could talk for quite a while about. It sounds somewhat complicated, so kudos to both of you for your expertise and knowledge and for being on top of that, because it sounds like there's a lot of rules. And I'm guessing that with Medicare, they probably change somewhat frequently as well.
Yes. So, they don't always make sense.
Yes.
Yes.
All right.
Good point.
Well, thank you for both Nancy Hyduke and Nancy Berland for joining me today in Fairview Range Focus, and it was fun to talk about that, and hopefully those that are watching learn a little bit more about utilization review, and should say as well that I know that we just kind of scratched the surface in regards to what care management does, and you touched a little bit about that, but so maybe we'll save that for another show. We could talk more about that, some of the discharge things. So, that's our show for today. And so I hope you enjoyed it. And if you'd like to learn more about some of the Fairview Range services that are offered, you can look online for us at www.range.fairview.org. So again, thanks to Nancy for talking about our utilization review. And thanks to you for watching Fairview Range Focus. And watch next month for the next segment. Thanks for watching.